Hello, and welcome back to The Wrinkle. Today we're doing a podcast with Dr. Michael Wang. He's a nephrologist, which is an internist and kidney specialist. He has lots of patients who are on dialysis, so we're going to talk about that. But we're also going to talk about how older adults manage with kidney disease. I'm Dr. Nicole Diddick, your host. So Michael, welcome. Thank you so much for
Pleasure
joining
to be
us. Here. Yeah. So why don't you tell us what is a nephrologist?
Yeah, so a nephrologist is a doctor that was trained in internal medicine and has chosen to specialize in the world of kidneys. So we look at kidney health through the entire spectrum. So anyone with slightly diminished kidney function, all the way to patients who require hemodialysis or peritoneal dialysis, which is basically an artificial way of supporting your kidney function when one's own kidneys have basically lost the ability to keep up with the body's demands. We also look after transplant recipients.
So quite a gamut. I mean, that's like a wide variety of things there that you just described, right?
Yes,
so people whose
part of the
kidneys
fun.
are, the fun. I don't think I found it super fun when I was in medical school or a residency program, but okay, that's great. So, if I can just share. So one of the things that I found kind of challenging when I was going through medical school and residency was that the people who were under the care of nephrologists, let's say, they were so complicated. And they were they were complicated. And I guess they were kind of frail almost by definition, like the fact that they had this significant problem with a really significant organ system. It made them very daunting to somebody like me who was kind of uninitiated and kind of new to it. So, I mean, what do you like about nephrology?
Yeah, so it's interesting that you brought that up. There was recently a study that came out looking at patients across various specialties, and there was some sort of scoring model to quantify their level of complexity. And nephrology actually ranked top of the list. And it factored in things like admission rates to the hospital, number of comorbidities that these patients have. So, what I like about it is, though, that you do have the opportunity to potentially make a pretty big difference in somebody's life. And you end up being kind of the quarterback sometimes of their overall health management. Our patients on dialysis will likely see us more frequently than any of their other doctors. On average, we see these patients about once a week. We end up knowing our dialysis patients very well. And not only because of the frequency of how often we're seeing them, but we've often met them earlier on when they just had some degree of chronic kidney disease that then progressed. We also are advocates for them and into their futures, whether they get kidney transplants or should they remain on dialysis. How do we ensure that they maintain a good quality of life on dialysis? So
okay. So you said you sometimes see people when they don't have much kidney disease or when they're well. Like what kind of a person comes to see a kidney specialist? Let's talk about older adults. So, what's a typical sort of older adult who comes to see a kidney doc?
The two most common reasons why people develop kidney problems in North America are diabetes and atherosclerotic disease, and that's tied to things like high blood pressures. I should mention that as people get older, the kidney function also declines. So that works in conjunction with underlying high blood pressure and diabetes. What usually triggers a referral to the nephrologist's office is a regular checkup of blood work. And there's a number called the GFR, or Glomerular Filtration Rate. That's just a fancy way of saying how much of blood is being filtered by the kidney on a given minute. Sometimes people express that as a rough percentage. So if your GFR is 30, sometimes an easy way of thinking about it, although not always accurate, is to think about it as having 30% kidney function. So when certain thresholds are met, that's what triggers a referral to a kidney specialist.
Okay. So what is that threshold? Like, what is it? Is 30 kind of a number that would usually get somebody's attention?
Definitely 30. And also now we are using the amount of protein in the urine, which is a sign of kidney stress. So even if it hasn't hit 30 on the GFR, if it's a little bit higher than that, but there's lots of protein in the urine, that also places somebody at a higher risk.
Okay, so your doctor might do a blood test, but they might also take a urine sample.
Yes.
Okay. Is that one of those lovely 24-hour urine samples?
Thankfully, no longer the case. Okay. Most often, it is a spot urine sample.
Okay. And so they just need a little spot of urine.
That's right.
They don't need a whole big jug. Okay. Yeah. Okay, that's good. Okay. So then this older person is kind of coming into your office and you talk about their kidney health with them. That sounds like a good thing. Talk about the principles of that.
Yeah. Most of the time, our conversation revolves around me giving them some reassurance. Why do I say that? Well, remember I was saying that the trigger for referral to the nephrologist is often a threshold of, say, a GFR of 30. Now, whether that GFR of 30 amounts to anything of importance to this person's life depends on a whole source of other factors. Mm-hmm. How quickly is it declining? How much protein is in the urine? What are the other medical conditions that this person has? In the majority of cases, especially in the elderly population, that low kidney function is just a function of their age plus the medical problems that they've lived with for many years. And if I track their kidney function numbers and prognosticate going forward, they actually don't necessarily have a high risk of progression to end-stage kidney failure, which is what we care about.
So that's cool. So you have sort of one of these little models you can predict what might happen going forward. That's good. Because you said that it's normal for kidney function to change as people get older. It's kind of normal for it to go down a bit.
That's right. Yeah.
That's true of a few different systems in the body, right?
That's
like
right.
The lungs, they start to change after the age of 30. Your lung capacity goes down. Okay. All right. So a lot of it is giving good news. But when I was a resident, I did not see those good news gang of people. So tell me about, because, you mentioned that thing that looked at the complexity of patients. I bet geriatric patients were pretty high up too, near the nephrology level. And so thinking about the person who's older, but also has even more layers of complexity. So the frail person, like what does frail mean to you in the kidney world?
Yeah, frailty is one of those things where it can be hard for me to place in words, but sometimes you have this feeling in your gut that when you see somebody, the way that they move, the way that they think, the way that they're able to function on a day-to-day basis, and the amount of assistance that they require to function, those are all things that I factor into my general assessment of frailty. We know that patients who are frail, who have medical complications stemming from other problems that they concurrently have, don't necessarily do well on dialysis. And so sometimes what I end up having as a discussion as they approach dialysis is a very honest talk about whether dialysis is necessarily right for my patient.
How does that go? That's hard because dialysis, so I mean, a lot of people who are listening might not sort of know exactly what dialysis is. So tell me more about that.
Dialysis is basically kidney replacement therapy, and it can come in a couple of different flavors. The most common way that patients now in our society receive dialysis is through in-center hemodialysis. What does this mean? It means that a machine is hooked up into their blood circuit, and the machine takes blood from the body, cleans it, and returns relatively cleaner blood back to their system. This is done in the hospital setting, usually 3 times a week, and each therapy lasts 4 hours.
Wow. So that's kind of a lot. I mean, you have to be fairly fit to adhere to that kind of
I describe
routine,
it as having almost like a part-time job.
Yeah.
When you factor in the travel and the waiting time before and after treatment, you can also have to be realistic that sometimes dialysis, especially after the treatments, can be tiring.
Mm-hmm.
It can cause symptoms. So while I might be able to keep somebody alive for some time longer, for some people that's not a good quality of life. And on the topic of the frail elderly person, sometimes the amount of life that I am buying with this invasive therapy may not necessarily even extend their lives by a meaningful margin.
That's pretty sobering. Yeah.
And that's where the education piece comes from. So, for example, in the population of patients in a long-term care facility, whether you start dialysis or not, usually equates to very marginal differences in the quantity, not even call it quantity of life, that the two groups experience. The average life expectancy of somebody in a long-term care facility who's starting dialysis is usually about 6 months. It's not so much because of the dialysis treatment per se, but I think it's usually more a reflection of the medical problems that they are bringing with them as they start dialysis.
Wow. So I didn't know that. I'm just kind of letting that sink in a little bit. So because I think of, and I know you were saying you're kind of the palliative champion on your team, and focusing on quality of life and not looking to lengthen life. And I think of dialysis as like a way to lengthen life. Like I think of it as being on life support in some ways, right? So that's really interesting that it doesn't necessarily lengthen life.
That's right.
For some people.
Some patients. And I am honest about it. Now, I sometimes end up starting dialysis because of very clear objectives. So maybe...
Like what?
My patient wants to ensure that he or she is able to live to see past a certain event.
Okay, like a wedding or something.
Sure, right.
Somebody graduating from medical school.
Sure, absolutely. Sometimes dialysis may be enough to play that fine line between, because it's also a treatment that can make certain symptoms get better, right? So as the kidney toxins build up, people can have itching, people can feel fatigued, people might feel a loss of appetite, not be able to enjoy food. That might be an important part of their lives.
Oh, sure, yeah.
And perhaps by putting them on dialysis, I'm able to allow them to enjoy some of these things again, or relieve some of their symptoms. I generally say in the patients who are a bit marginal, meaning that I don't know how much longer I can sustain them on dialysis, or if they have some illness that's going to be probably the limiting factor to their lives, I say if at any point you find that you are no longer getting much out of this treatment, if you find it unbearable to come to the treatment sessions, if we're getting more negatives than pluses, let me know at any time, because this can always be stopped.
Yeah. Those are big conversations and
are.
big decisions for people to make. But they sound like they're really important. Yeah. I think I remember seeing, it's funny when you mentioned that big life event, I remember a guy who I saw in my office who was an older fellow, and he had a lot of trouble walking, but he was also on dialysis, but he had a granddaughter who was getting married. And it was so important to the granddaughter and to him and the whole family that he be there to kind of walk her down the aisle.
Sure.
or roll her down the aisle in his wheelchair.
Yeah.
And he used dialysis. He was on dialysis for that, to sort of stay as well as he could, to keep him out of hospital. And then they had this celebration, and I remember he brought in photos of the day, and it was beautiful.
Mm-hmm.
And but now he kind of came to see me because he sort of wanted to review whether or not that was still the way to go for the family. And in the end, he kind of decided that it probably wasn't. But he lived for another, I think it was more than a couple months afterwards, even after he stopped dialysis. But it was a very peaceful thing that was able to happen.
And that can, on the topic of life expectancy after stopping dialysis, that can depend largely on how much residual or remaining kidney function is left. So for some patients, they may still have some decent amount of kidney function, especially if they're able to urinate a fair amount of quantity of urine. The dialysis was in place just so that they don't get major toxin syndromes. And stopping dialysis in these patients may still result in that person living for weeks.
Yeah. Now, aren't there some ways too, because probably some people who are listening know someone who does dialysis at home, or does it not through the blood, but there's other ways of doing it. So are those methods suitable for older people? Yeah.
So the two types of treatments that you're referring to are peritoneal dialysis, which is dialysis using the membrane of the peritoneum, so using the belly to essentially cycle fluid in and out as a way of washing away the toxins. And home hemodialysis, which is the same principle of the blood dialysis that I was referring to earlier that people usually get in the hospital, but for the more functionally capable patients, they can actually learn to be their own nurse and do it themselves.
Wow, that's amazing.
It is quite a sight to see. It's very nice to see patients getting empowered like that. For the elderly population, the home hemodialysis may be challenging if their functional status is lower. Peritoneal dialysis does require some functional capacity as well, although if family members are able to help, or we are able to meet them halfway with some community assistance from nurses, then that could still be an option for the patients. Peritoneal dialysis offers one big advantage, which is that patients don't need to come to the hospital so many times.
Now, is that ever a good thing in long-term care? Have you had anybody who's done peritoneal dialysis in long-term care or home hemo in long-term care?
No, because of the limitations it can happen, but the major challenges is ensuring that nurses are able to handle.
Okay. So if somebody's in a home, there might be staff there and they may not feel equipped to manage all of that. Correct. Okay. Yeah. Well, that makes sense. So speaking of long-term care, so it sounds like a lot of these discussions are very detailed and they're very important. So someone who's making those kind of decisions about, should I go on dialysis? Should I continue dialysis? You need all your faculties to kind of grasp that. What about if somebody has a cognitive impairment? So what if someone's living with Alzheimer's or another kind of dementia? I'm thinking of someone that I'm looking after right now in the hospital who has a significant dementia and also is on dialysis, and it's hard to know the way forward, you know? So we're kind of in I think sometimes people kind of stay in a holding pattern, but someday they're going to come into Dr. Wang's office or some other nephrologist. What about that?
Any type of time that we're dealing with conversations of this gravity, it's always very useful, if possible, to involve other family members or people close to the patient. And that is especially the case if the patient isn't able to have these conversations himself or herself. So frequently I am having these discussions with family members instead of the patient. It's a hard conversation to have, and I absolutely empathize and sympathize with the family members who are now faced with these big decisions. I generally remind them that the decisions that they are coming to is based off of their understanding of what their loved one would have wanted.
That's critical, right?
Yeah.
So you can't do what you want. You've got to
Yes.
think about what the person would say if they didn't have Alzheimer's.
And the things to help with that decision-making process is to reflect on certain questions like, well, what was my loved one like when he or she was better? What was the things that they found value in? What were the things that they were proud of? Or what were the things that they really did not like and maybe felt was diminishing of their honor or their integrity as a person? And the more you reflect on that person's life, I think these answers start emerging. So in some ways, you almost have to step back from the medical problem in front of you and just reflect on the patient's life.
How often do we do that in medicine, though? Like you and I, we're physicians here. So that's hard for us to do, right?
Hard.
We don't really get a lot of training in doing that. Are there tools that you know of or that you use that to help with some of these discussions or that you give to families?
I think I was very lucky to have trained with some fantastic mentors, both in nephrology but also in the fields of palliative care. And that allowed me a sense of how to have these conversations. In terms of resources, I'm sure there are. I wish I knew off the top of my head, but I don't. The tools that I do use from a clinical, almost biomedical side of things is there are certain prognosticating tools. So the numbers that I was speaking about earlier about what's the life expectancy of such and such a person, those score calculators are available.
Okay. So that's something that a clinician could sort of use. Yeah. You know, we mentioned medical students. We have a student here with us today. He's sitting here very attentively in the background, but his name is Ethan. So Ethan, maybe we can bring you into the conversation. So just we're kind of reflecting on not really having the tools to have these tough discussions. You're a first-year medical student. How do you feel? I mean, hearing all of this, do you feel worried? Do you feel excited about some of this? Tell us your thoughts.
Sure. Well, I feel like it's very important to look at the issue from the patient's perspective. And I think that that's just our job as physicians, to just really explore what can be done, not just from the medical angle, but also from the psychosocial angle of how patient's quality of life will shape up in the future with this treatment, or if another path forward is taken.
Now you're doing an elective right now in nephrology, so that's a pretty high level one for a first year medical student. Why did you decide to come and work with Dr. Wang?
Well, I find that Dr. Wang is a phenomenal teacher, and I've always just had more of an interest in the clinical side of getting to interact with patients, looking at complex cases like the ones found in nephrology. Okay. And
so you don't have any personal experience with dialysis or kidney disease or anything, do you? No. Okay. Oh, or that you want to disclose on a live podcast. That's not a live podcast, but okay. Well, that's good. Neat. So have you seen any of these types of challenging conversations that we're talking about where we have to talk about initiating dialysis or not?
Actually, I've not been privy to such conversations as of yet.
We're going to have one this afternoon, actually.
Oh.
Okay.
Yes.
Yeah.
So that will be, and so these things do pop up on a fairly regular basis.
Yeah.
So our population is the same one at the end of the day. And helping our patients involves everything from dealing with ways to extend their life to making their lives more have better quality, to helping them navigate the deep questions of life. You know, it's all part of the job.
Wow. It's a great job. Now, before we finish, you mentioned transplant, which I think is another thing that our listeners and probably Ethan, would find very interesting. So we're talking about older folks now. would an older adult qualify for a kidney transplant?
The oldest patient I've seen personally get a kidney transplant was in his early or perhaps even mid-80s.
Wow.
And the thing that I always tell patients is that your age is more than a number. It is the level of health that you're currently living with. And so you could have somebody in their 40s that has unfortunately accumulated a lot of medical problems. And that person will be a higher transplant risk than someone who is in his or her late 70s, early 80s, who has had a relatively clean bill of health. So it's not just a number, and I think that applies to so many other aspects of healthcare of the elderly as well.
Okay, so that's exciting. So age is not necessarily a barrier to transplant. No. Okay, that's cool. And if a person does go through a transplant, like what's life like after a transplant?
The first year can be challenging, and that's where some of the very careful why we have such careful screening for transplant recipients. So if you follow life expectancy, for example, of patients who have gotten a transplant versus after dialysis, the patients who end up with a transplant actually have a higher mortality risk the first year. But soon after that, they catch up, and then the mortality risk is less than on dialysis. Okay. So I always say that if possible, a kidney transplant does statistically result in a longer lifespan, but probably more important for them is the quality of life. Okay. Where now you don't have to do any form of kidney replacement therapy.
Right. So the freedom from that chore, that part-time job.
Yes.
That you talked about. Yes. Yeah. Well, that's cool. So what could we do? Let's just bring it back to palliative care for a bit. What would we do? What could we sort of do better to provide better sort of palliative care and symptom management care for people who are living with kidney disease?
There's probably two pieces that come to mind. The first is not having that discussion at the last minute. So advanced care directives are increasingly part of our consciousness and awareness. And we are having that discussion much earlier. And it doesn't have to be so focused on the very concrete. It could be a more exploration of what are the things that you find valuable in your life. What are the things that you don't want to live through? The second piece that came to mind is tailoring our traditional medical management algorithms towards one that is more specific to the individual. So in nephrology, we are very focused on numbers. We have a lot of data to work with. And traditionally, and unfortunately, it is the case still in the States because of the way that the funding models can be tied to dialysis care. There are certain quantities that people thrive for. What is the phosphorus level? What is the hemoglobin level? Are these things patient important matters? Not really. Do we have great data to support that by meeting those targets, you make somebody's quality of life better? Definitely not. Do we have great data that they even make someone live longer? Not great either. Most of our studies are observational studies. So I think that one thing we need to do better is trying to understand that not everyone needs to have the same formulaic treatment. Some patients may do just fine on twice-a-week dialysis. Some people it may be okay to let their phosphorus ride a little bit higher if it means that they're able to enjoy the foods that they enjoy.
You just blew my mind a little bit there. Because you can tell I was very influenced by my residency experience in nephrology, but it was all about numbers. Like I think we started our day by looking at all those numbers and then adjusting the medicines accordingly. And it's such a careful chemistry type of experiment, you know. That would be amazingly freeing.
I think the paradigm has changed. I think it is. It's either changed or in the process of changing.
That's so cool. I hope that's true in a lot of places, because I think we do focus on a lot of metrics that we shouldn't be metricing, you know? They don't make a lot of sense.
100%.
Yeah.
Yeah.
And advanced care planning is important too. But you know, it is hard, because I think we don't want to, I mean, I know I've looked at those advancedcareplanning.org, like there's websites, there's workbooks. They really do make it easy, but you just don't want to think about that stuff.
No.
And you don't want to have those conversations. And sometimes you don't want your family to have to think about it either, because you have to you have to sort of project to a time when you might not be there, or you might not speak, be able to speak for yourself. And I think it's hard for family to think of their family member being that
absolutely
way.
Very hard.
Yeah. That's so cool.
Yeah.
So anything else that we should talk about, do you think? I feel like we've covered a lot, but it's gone pretty fast. But we've been talking for about 30 minutes. Yeah.
Well, there's probably endless things to talk about here. I think this is a nice way to end things for this podcast.
Okay.
I'd be happy to come back if there are other areas that we feel are worthwhile exploring.
Absolutely. Yeah. Well, and our focus is on older people. I mean, I think people would love to hear how they can, promote their good kidney health when they're just getting into that older age group.
Yes.
Because, people are always talking about prevention, and they want to know about superfoods and things like that. And so knowing how to eat and how to exercise and drink or not drink for your kidneys, that would be really cool.
Yes, I could speak another half an hour about that as well.
Okay, that sounds good. Well, we will have you back. And maybe we'll have Ethan back as well, the medical student. So Ethan, what do you think? Did you learn something listening to Dr. Wang?
I definitely learned quite a lot. That is actually a very interesting point you raised about how everybody can deal with different kinds of treatments. And I definitely back to watch.
Excellent.
Wonderful.
Very good. Well, thanks so much for joining us for this episode of our podcast on The Wrinkle. If you want to hear more Wrinkle, all of our material is on our website, www.thewrinkle.ca. I've been talking to Dr. Michael Wang. He is an adjunct assistant clinical professor at the McMaster University Michael G. DeGroote School of Medicine. He's a nephrologist in Southern Ontario. And I'm Dr. Nicole Diddick. See you next time on The Wrinkle.